A quick note before we start, you can find all links and resources discussed in the video description, and please use them to support us. Please also comment, share your opinions and ask any questions. Thank you and enjoy. Thank you for joining us, Dr. Daniel Lewandowski. Dr. Lewandowski is now a second year in core surgical training in Wales, and today we're going to cover a bit about the process of applying to your surgical specialty and what you should be doing when you're a medical student to prepare for this, what you should be doing during your foundation year. And then we'll talk a bit about the exams, how to prepare, and how to ultimately build up your portfolio and everything that you need to do for your specialty. So thanks again.
Sounds good. Yeah, thank you for having me. I'll try and explain everything as best as I can, but we'll see what happens. First question.
So what is the basic timeline of the steps to apply to a specialty? So what is the very first thing that you'll be doing?
Yeah, so if you guys apply to the UK, the first thing you do is obviously apply to foundation program. Once you have a job in foundations, either you'll get a 1 or 2 year term. So in most of the UK, England, Scotland, for example, usually they'll give you 2 years, and you can see each of your jobs in those 2 years for the foundation program. Whereas Wales is a bit different at the moment, where you apply separately for each year. So when you apply for F1, you'll rank the jobs that you want in F1, and then you redo that when you get into F2.
I think it depends where you apply. Sometimes they have 2 year programs as well.
Yeah, exactly. So for the most part, I would say everywhere else apart from Wales, I believe, is 2 year programs. So you see exactly what you would have over the 2 years. Whereas in Wales, you'll redo it after your first year. So it is slightly competitive in the second year to get whichever program you may want. I know that like plastic surgery and stuff like that, if you aspire to be a plastic surgeon, those jobs are slightly more competitive. But yeah. Okay. And then after you're done foundation program, you apply for core surgical training, which is what we'll talk about today. And that's also a 2 year program, which is beginning to be a lot more competitive in the last few years. I think I looked at the ratio was the competition ratio was about 4.16 to 1, meaning for every 4.16 applicants, there's one job, which has increased dramatically over the last, I think, 5 to 6 years, where it used to be less than 2 to 1. So not just core surgical training, but a lot of jobs are becoming more competitive. So yeah.
So when we're thinking about the applying to the core surgical training, I think you have 3 kind of main steps, I think, right? You have the MRC exam, the interview, and
your self-assessment score.
Yeah. Is that all of them? And like when do you do each of these?
So MSRA is a new exam that they've introduced the year after I got into core surgical training. I think that was 2022, I want to say. I have more details about that exam in a second, but essentially that makes up 10% of your score. Your self-assessment score, which is out of 52, it's a detailed score in terms of your teaching experience, commitment to specialty, poster and oral presentations, previous degrees you may have, and things like that. That score is out of 52, where you self-assess yourself. You submit your evidence. So for each point, you submit the evidence where you think you should score. And then they'll tell you if they agree with you. If not, they'll give you a score and you could appeal it if you don't think it's correct. And then the last part of the score, which is where 60% of your core surgical training mark, is the interview itself.
Okay, and just the MRSA exam, when would you expect?
MRSA is...
When would you expect to take it? Are you taking that during the foundation program or after?
So MSRA, when you apply to core surgical training, so the timeline I have from last year shows that the applications open on the 26th of October of this past year, and then they close the 23rd of November, meaning you get about a month to apply. The invitation to do the MSRA came out December 19th. Okay. And then the window to do the test was from the 4th to the 16th of January this year. After that point, from February 8th to the 14th, evidence upload window. So all your evidence for your self-assessment score you'd upload. You found out your MSRA results on February 8th this year. And then that was also your invitation to have an interview. So in terms of the MSRA, which is new, the top 1,200 scores would have an interview. So where in previous years, the self-assessment score was the main drive in terms of how you got an interview. The higher your self-assessment was, obviously the easier it was to get an interview. But now it's based, the first hurdle is the MSRA. So you need to score in the top 1,200 people to get an interview. And there's always about 600 jobs for core surgical training. So at that point, if you do get an interview, it's a 2-to-1 competition ratio. So, you just have to be better than the other guy to get the job. And then you do the same thing like in F1, F2, you preference your jobs. So, if there's 600 jobs, you want to preference all of them essentially, because if you only rank, 50 jobs and you don't score in the first 50, then you won't have a job, unfortunately. And then the offers this year are sent out on March 26th. And then there's things about holding or upgrading your jobs, and that happens in April. And then you start your post. This year will be August 7th, 2024.
Okay, and where are you applying on? Is it because if a
It's
foundation
Oriel,
program?
so it's the same system that you apply for F1, F2. Yeah, same type of ranking. It's all very similar things. In terms of, if I go into more detail about the MSRA exam, so it stands for the Multi-Specialty Recruitment Assessment, and it's it's broken down into two parts: the professional dilemmas part and the clinical problem-solving paper. The professional dilemmas paper, it's a 95-minute sort of situational judgment sort of test, which people historically would remember the SJT from when they applied for F1, F2. It says here they have 50 questions on that, and then you rank, you get 4 or 5 responses, you rank them from, most likely that you would do to least likely, and that makes up half the paper. Second half of the paper is the clinical problem solving. That's 75 minutes, 97 questions, split into 2 sections. First one is matching, where you're given 7 to 10 responses and asked to choose the most appropriate 3, which is similar to what was on the SJT before. And then second part is single best answer questions, where you're given a scenario and you have to pick the most appropriate response. And that's what makes up the MSRA. So it's a total at the moment of 147 questions.
Okay. And regarding the MSRA, because you didn't take it.
No.
But
thank God.
But do you have any idea of, how long people usually prepare for this exam? What kind of things?
So it's a bit tricky to say, because obviously everyone's different in terms of how they study. But I remember the first year they introduced it, they introduced it only a couple of months before people actually had to write the exam. So for people doing other exams or, other work and stuff, it was quite stressful at the time. And there was a lot of, what's the word I'm looking for? A lot of people were like angry with it, and they wrote to the college saying, it's not fair to introduce this exam when we haven't, weren't aware of that as an application formality. So usually I would say people 2 to 3 months they study for the exam. Like there are question banks which you could purchase online, and I'm sure they've developed books now. But because I didn't do it before, I'm not too familiar with the question banks, but I know they are available. There's thousands of questions you could do, but I assume they're similar to the SJT questions in the past. So if you have any, like old SJT books, obviously that would help you out as well. Ranking, from 1 to 5, best answer, things like that. Or pick 3 from the 7. So yeah, I've spoken to a couple of people about it, and they said question banks are quite good. But it's, all over from different specialties, the exam.
And when can people take this exam? Can they take it during their foundation program, or do they have to complete it first and then they can apply?
So I think you could only take it the year as you're applying for CST. So in terms of the recruitment timeline, which I explained before, you apply for CST. This past year was October. Deadline closed in November. And then when they deem you're eligible, they send you an invitation to take the MSRA. So usually if you're applying for CST, let's say coming out of F2, it would be a few months after you start your F2 job in October, let's say, to apply for core surgical training and then get the invitation to do the exam. And the exam happens once a year in January over a 2-week period. And you could book that online. And it happens in the Pearson VUE testing centers. So different cities will obviously accommodate you depending where you live.
Okay. And so that's the MSRA exam. And then the next step is this self-assessment, kind of building your portfolio.
Yeah. So in terms of self-assessment, it's out of 52 marks. I have a copy of all the marks here. So it's pretty much broken down into your commitment to specialty, your teaching, operative experience, any oral or oral presentations or poster presentations, and then a few other bits. So to go through it very quickly, for example, if you have when you're in F1 and F2, hopefully you'll have the time to go to theater. If you have 40 or more cases in your e-log book, which you'll hear about at some later point, that gives you max points for your operative experience, which gives you 8 out of 8. Another example is attending surgical conferences. So if you attend 3 surgical conferences in any surgical specialty, you'll get max points in that section, which would be 3 out of 3. In terms of surgical experience from the past, they allow you to take a taster week in a surgical specialty when you're in F1, F2. And what that means is you would write to the department, let's say, for example, I don't know, urology. If you're interested to do urology, you'd write to the department saying, I'm a keen F1 to do hopefully urology in the future. Could you accommodate me to do a taster week for 1 week, 5 days, to sort of shadow either the core surgical trainees or the registrars in that job in order to get, more insight about how that job functions. And if you do that, you get max points in that area of your application, which is another 3 out of 3. If you have something like an elective, sorry, go ahead.
I was just going to ask, like when you're doing F1, F2, and you have your surgical rotations, are surgical rotations in F1 versus F2, are they weighed differently? Like,
so those wouldn't count because they're part of your job plan, so they're not taster days. So it would have to be a different specialty. Let's say you're doing trauma orthopedics in F1. You would have to pick a different specialty to qualify as a taster day. Or if you've done electives in your 6th year of medical school, that would count for 2 out of 3 points in that section of your application, as long as you have 4, it says minimum 4 weeks.
And so these are specifically like extra beyond your job.
Sort of an extra week in a surgical specialty apart from your normal job. So, in F1, usually they'll give you a medical job, a surgical job, and then something in between like A&E. What did I have? I had endocrinology / gen med. Then I had trauma orthopedics, and then I had gen surg as well. So if I did gen surg and trauma orthopedics, both of those are surgical specialties. I couldn't do a taster week in one of them, so I'd have to pick a different specialty. For example, urology, neurosurgery, max fax, whatever. To qualify as the taster week. But if you have a month of electives in your last year of medical school, that would also qualify you for 2 out of 3 points.
And so what's the name of this category for the portfolio?
This one's called surgical experience.
Okay.
Yeah.
So
and then going further on, for your points, you have the quality improvement or clinical audit section, which gives you a maximum of 8 points. So if you were involved in all aspects of a surgically themed clinical audit or QI that demonstrated change in terms of you have to do 2 cycles. So you do your original audit, show statistics that, for example, VTE prophylaxis is 80% compliant in trauma orthopedics. You present your findings to your local department in an audit meeting. And then, you try and develop change in terms of better compliance, awareness, and things like that. And then you'll audit again, hopefully with improved results. And once you do that second cycle of the audit, that's what would qualify you for max points, which is 8 out of 8 in that section. And then you have a presentation and publication section. So it's difficult for people to get publications. If you have publications in medical school, great. If you don't, I wouldn't stress too much. I didn't have publications applying for core surgical training, which is why they also have the presentation section, and it's merged now into one. So if you are first author on a publication that's PubMed indexed, you get 10 out of 10 points for that. Whereas the other side of this section is if you've had an oral presentation and you've received a prize for that presentation at any conference, you get max points 10 out of 10. And then the list goes down in terms of, delivering an oral presentation at a national or international meeting gets you 8 points. So if you go to, Wrocław or Poznań for some sort of a international national conference and you deliver an oral presentation, then you'll get 8 out of 10, which is still pretty good. And then going down to finally sort of teaching experience, the last section. If you develop, they've changed the wording now, so it has to be face-to-face teaching with 4 or more sessions. You'll get 10 out of 10 points.
Does that mean it can be online or?
See, I don't know. That's a bit iffy. It says face-to-face, so I don't know. I think that means not online. Although it is face-to-face now. I don't think, I don't know. People would have to clarify, but then it says that 8 points. I've worked with local educators to design and organize a teaching program for more sessions. So it doesn't say face-to-face in that one. So I'm pretty sure you could do online.
Okay.
So you probably have to clarify in terms of max points for that, but I assume face-to-face means like in-person teaching. So you design, I don't know, a series of 5 teachings about getting into F1 or, orthopedic training or other random stuff would get you max points in that section. Or for example, teaching, even if you guys are in your final year of medical school, teaching the first years, about whatever topics to help them when they get into the clinical classes, that could be considered face-to-face teaching. You would need things signed off by like your dean or your vice dean to prove that, but I don't see why not that could be one.
And so is that all the sections for the portfolio?
Yeah, and then training qualifications is the last one, where essentially it means if you have something like a PG cert in medical education, you could get 5 points out of that section. Training and teaching methods lasting 2 or more days will get you 3 points. And then any training and teaching methods is 1 point. So if you attend any sort of, I've attended, for example, a teaching the teachers course, which was over a couple of days, which gave me 3 out of, I can't remember, the scoring was different when I applied, but gave me a decent amount of points for that section. But if you do have a PG cert in medical education, you get 5 points for that.
Okay. And just to try and understand, I guess my question is, which of these things can be done as a medical student? Like some of the things we've mentioned is the conferences, right? Doing any research.
Yeah.
If you can present, if you can publish, these are all things, or win an award at a conference. These are all things.
So mainly I would say the presentations, the conference stuff, the surgical cases that you scrub in for. I don't think you'd be able to do that in medical school, because we have something called e-logbook, where you log on and you have to give sort of the patient number and then what the surgery was, where it was. So that's all UK based. So you wouldn't be able to do that in medical school. Conferences you could do. Yeah, there's no problem there. The posters, the audit you would have to do while you're F1, F2. Teaching you could do in medical school, like you're doing right now. If you have 4 sessions of, teaching the medical students about something, that would qualify as 8 points, I guess, because it's not technically face-to-face. And then, if you want, you could do a PG cert in medical education if you're in medical school, but, with all your exams and other things, it might be a bit difficult. a PG cert here is mostly done online. Uh, Stands for postgraduate certificate in medical education, and what that is it's online modules and things like that about delivering teaching to teaching methodology and things like that. And you get a certificate after a year. They usually range from about £3,000 to £4,000. So it is costly, but it gets you 5 points now out of 52 for that, for your CST application, which is almost 10% of your application if you do get a PG cert. But if you don't have one, no worries. You can make up your score in other areas.
So usually a PG cert takes 1 year. And
yeah, I've seen places that do it in 6 months because it is online for most of it. So it depends how fast you want to do it. If you have time, great. If you don't, then you could, I think the max amount of time you could have for it is about a year. I did a PG cert in surgery, which I think they give you, I think it was a year for, but I did it in a couple months because it's online modules. And you do quizzes after each module. You need to score, I think, 80% or something on each one. And then after you accumulate a certain amount of credits for different modules, then you get the PG certificate. So I got one in surgery, but it took me only a couple months because you pay for each individual module, but then you also have to do the tests. So it's financial in terms of you need to have the money to pay for it because it is quite costly, but also if you have the time to do it. So that's why they give you like up to a year to do these things. Because if you don't have the time every single week to put in some time, you can sit down and do it whenever you have availability.
so when can you, or where do you apply to do a PG cert? Is this like through your trust or?
If you look online, PG cert in medical education, most universities in the UK will offer one. There are some new websites. I think iHeed is one, IHEED, where they do a lot of online modules and things like that. I keep receiving advertisements. I don't know why, but I've seen they advertise it for 6 months. But yeah, they're costly at like £3,000 to £4,000. But if you type it into Google, you'll see that a lot of universities all over the UK offer them. And they could be from far away. You don't need to be there. It's just recognized by that university because everything you're doing is online. You may have essays that you need to submit, but that'll also be done online. Your modules will be done online. Your quizzes, if you have any, and tests will be done online. But from what I know from people who have taken a PG cert, there's a few essays that you have to do, and that's what makes up most of your mark.
Okay. And is it something that you think is possible to be doing as a medical student, or some years
like I
are a
said,
bit
it
more
depends on
relaxed?
time and money. If you have time and money, go for it. If you don't, it might be a bit difficult.
Yeah.
It's also difficult to do it in F1 because as you're transitioning into, being a medical student to an actual doctor, life's different. It's difficult, for example, in the first couple months, depending on where your training was and how much training you've had before. But once you get into the groove of things, I'd say it'd be, if you want to do one, I would say F1 and F2 is the time to do it because later on in your training, you'll have to do other things, such as your MRCS, and other exams, life, babies, marriage. You won't have time. Yeah. So I would try and do those things as early as you can because later on it's a bit more difficult.
Okay. So, and then, so those are things we can do like during as a medical student. And then, I mean, we've already touched on it, but the things that you should be doing during your foundation program is getting those surgical cases whenever you can.
Yeah,
Try
40
and do a
cases
case.
seems like a lot, but it's difficult sometimes for an F1 to get into theater. So I think F2 you'll have more possibility, but if you think about it, you're having to submit your evidence by February of that year. So you'll have pretty much your first job will take you from August to December, and then December to February is about 2 months of the second job to get those 40 cases.
So in many ways, if someone wants to be doing CST immediately after F2, then they should be looking at rotations where surgically is one of the first ones for F2.
Yeah, exactly. Because then it puts you at a disadvantage if you have for whatever reason, a medical job in something else. Like usually people will get a job in A&E in their F2, but there's no surgical aspect to that. It's A&E. So you need to sort of be strategic in when your rotations are, and also try and do as much as you can in F1, although that may be a bit difficult to get those cases. But yeah, 40 puts you in, it gives you the max score for that section, which was, what did I say, 8 points, I believe. Yeah.
And what's your experience with the kind of opportunities available with doing research and publications during the foundation program?
So there are opportunities, but it is difficult. Like I said, I didn't have any publications going into CST. There's lots of research opportunities, which I've been involved in mostly with trauma orthopedics. Last year, yeah, I did an oral presentation at a national conference and actually ended up winning the prize for it. We were looking at laminar flow in trauma and orthopedic theaters. So it is a bit of research which we're going to try and write up now in order to get a publication out of it. And hopefully, that'll give me more points for when I apply for registrar training this year. It depends on who you work with and if the department is keen on research. So I know in trauma orthopedics, which is mostly what I've done, certain consultants will have more publications than others. So it's good to get to know your consultants, see if they're the type that are keen on publications and research, and ask them how you could help out. You don't need to be first author or anything. Your name just has to be on a publication to get those points. Obviously, if you're first author, you get more points, but a lot of people don't have publications going into CST. So any type of research or things like that you could do in F1, F2 is quite beneficial, but it is difficult. It's, going out of your own way to try and seek these things. So you also have to have time and commitment to do any research or publication stuff, but it is possible.
How are case reports and publications, how are they viewed? Are they a different level, or what do people think?
It depends on the level, like the quality of your publication, because you could publish something and put it into like a journal that's not well known. So depending, I'm not going to get into the specifics, but impact factors is something that gives sort of the strength and ranking of a journal. So if you have a high impact factor, it means your journal is quite good, whereas a low impact factor means, most people could just pay to get something published and it doesn't have much meaning. Case reports, on the other hand, are like single cases that you may have, and you can get them published in relatively good journals. I believe for application projects, I believe for applications, case reports have the same weighting as publications, because if you're first author on the case report and it's PubMed index, I'm pretty sure it would have the same weighting when you apply. And that's another thing I'm also working on. We're doing a case report on an interesting case we saw last year in trauma orthopedics. So I've currently submitted that to a conference in Wales, waiting to hear back from that, and then hopefully we'll write it up in one of the journals.
Okay. And moving on from there, you may have finished F2. Maybe you didn't get maybe someone didn't get a spot, or maybe they've decided to delay their application for CST. So after foundation program, what kind of options do they have for work, but also what kind of options do they have that can benefit their CST application?
Yeah, so that's exactly what happened to me. So my first couple of years I applied for CST, I didn't get in, unfortunately. Like I said, the competition ratios keep increasing every year. So the 2 years that I didn't get into CST, it took me the third time. First couple of years, I ended up doing a clinical. So first year I did a clinical research job in trauma orthopedics, which actually relates to your previous research questions. You could find jobs that sort of have a research element, where in that job, I was given 1 month at a time to dedicate most of that time to research work instead of any clinical stuff. So in those months, I'd be on call some of the time, but usually I wouldn't have to do any clinical work on the other days. It'd be more research oriented. So that job was over 12 months. And then I also did a trauma fellow job for 12 months, both in Cardiff in the trauma orthopedic department. So people that don't get into core surgical training, there's many opportunities. You could do a teaching fellow job, for example, where you have clinical work, but you also give teaching, for example, once a week, something like that. And they help boost certain areas of your self-assessment score. So if you don't get in, you need to look at which areas, you scored lower than you would like and try and boost those areas, whether that's research, whether that's teaching, whatever that is. There's jobs that are tailored to those areas, if you want to call them, like a research fellow job, teaching fellow job, which help you with your application. So if you don't get in, I'd recommend doing one of those types of jobs, something that'll help boost your application. You don't want to do a job just to do a job. You can if you want, but at that point you might as well just locum and make more money, which is a whole other field, which we won't get into. But if you don't get in, it's honestly looking at what you need to improve in your portfolio assessment and trying to maximize points there.
Okay. And just to clarify, it's your MSRA score plus your self-assessment score is a deciding factor on whether you get an interview.
Not self-assessment anymore. So MSRA, purely the deciding factor. So only the 1,200 top scores of the MSRA for when you write it will get into at least this is how I understand it, we'll get into the application process. The interview process. So if you rank top 1,200 out of, I don't know, let's say 4,000 people do the exam, you get into the interviews. At that point, 30% of your self-assessment score is taken into consideration, and then 60% from your interview. So from my understanding, you could have, a very poor self-assessment score. Let's say you only get half of the marks, 26 out of 52. That does put you at a slighter disadvantage because from 30% of the final mark, that means you only get 15, if that makes sense.
Yeah.
And then depending on how well you do in your interview, the interview has the most weighting. So if you kill the interview and get almost like perfect, that's 60 marks out of 60 there. And then the others, you want to do well in, but are less relevant. But yeah, the reason for the MSRA being a low score is sort of just to weed out the other 12, you just want the top 1,200 people, and then the rest follows.
Okay, so then at the end, it's your MSRA, your interview, and your self-assessment with the percentage split, right? 10% MSRA, 30% self-assessment, 60% interview.
Yeah.
And that is like the kind of the final.
Yeah, that makes up, 100% of your mark. So depending how you score in each section, because MSRA is only 10%, I don't know how they do, but if you get like 70% on the exam, maybe they do it 7 out of 10 for that, or it'll be the ranking in terms of what percentile you are. So if you're, the top mark for the MSRA score that year, then you'd have 10 out of 10. I'm not entirely sure how they do it. But that being said, year to year, the threshold of the top 1,200 people may differ. So, this past year in January, let's say the person who was the 1,200th score had, 65% and they got in, great. Next year might be, that 1,200th person might be, 70% or something. So you never really know. And it's similar with when you do MRCS, they look at all the scores and they sort of, standardize it on a curve and then plot out what they want as their passing mark.
Okay. And then with regards to the interview, how does the interview look? Is it online? Is it in person? Or
it used to be in person. So the first time I ever did it was in person in London, but they don't do it anymore. They do it online. So before you have your interview, they send you an email with, what to prepare for. And usually you'll give a 3-minute speech about leadership. I would need to brush up on all the topics they want, but 3-minute presentation on leadership and how leadership will help you be a successful core surgical trainee. Then they'll ask a couple questions about leadership. They'll give you sort of an ethical scenario. where it's sort of like SJT based. Like, for example, you have a colleague looking at your other colleagues, I don't know, blood results or whatever, for example, and they'll ask you to walk them through like your thinking process and how would you approach this. They could ask you questions about like clinical audit, for example, and what types of audits you've done. And then usually um, you'll get two clinical scenarios where one most of the time is something related to trauma A&E, and then you'll have another one from a different specialty.
Okay. And how can you prepare for the interview?
So
Is it something you can prepare for?
there's books to prepare. There are courses you could use to prepare. MedAll, which is a good platform. There's a lot of different schools and hospitals that offer preparation for core surgical interviews. I used a book. There's courses online, and there's a website called MediBuddy, which I'm not sponsored by, but that's what I used. And I think it was like £70 or whatever. And they give you a lot of the scenarios for it. Yeah, so question bank from MediBuddy is £85 now. And it gives you, an extensive amount of questions to practice from. And I found it very helpful, the way they explain things. So they'll give you, for example, what do we have here? Trauma chest pain scenario. Or this one they've done here is abdominal pain. So it says, you are the surgical SHO on call. You're referred a 29-year-old female patient complaining of severe and unremitting peri-umbilical pain. The pain has been worsening over the last 2 days and is now localizing in the right flank. They give you the observations, and then on the MediBuddy website, it asks you a series of questions. So the first one here is how you would proceed to initially assess this patient. Second question, what are your differential diagnosis? And this is all types of things which you'll want to do in your interview as well. They give you a scenario. You want to say how you'll assess them. You'll assess them with an A to E approach using ATLS or ALS principles. What do you think is the problem? So give a diagnosis. So, if they give you something like a DVT, you could say, my main concern is a DVT here, but I would also want to rule out blah, 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 infection or other things. Here for this abdominal pain question, it says, what are the classical examination findings for a patient with acute appendicitis? Where is McBurney's point located? How do you elicit Robson's sign? What are the variations in the anatomical position of the appendix? What investigations would you order in this case? And do you know of any scoring systems to assess the severity of appendicitis? So this scenario is obviously very heavily related to appendicitis. So given the scenario that they've given to you, you're thinking about appendicitis, and then all of these follow-up questions get you thinking about appendicitis, what investigations you need to order, and how you would examine the patient clinically. So I found MediBuddy very helpful. So 85, what is that in zloty? 450, 500 zloty, let's say.
Yeah.
But it's here, it says it expires 1st of May. I don't know how helpful that is because the interview's, when did I say? February. So there's no point of ordering this now, but as you're preparing for something, get these kinds of question banks early, because going through them is quite helpful, whether you have someone else to prepare with, which I would highly recommend. It's very good to have sort of a study partner for the interview for two reasons. One, you're always, speaking to someone, they could be asking you the questions, but it's also good to not only get feedback from them, but also see how they answer questions. So, people have different styles of answering things, and you may pick out one or two things that you like what they do and incorporate it into your answers. So it's always good to sort of have at least one person you do interview prep with, or a group of you, in order to bounce off ideas off of each other.
Then later on, once all of these scores have been submitted and so forth, is this when you start ranking the jobs?
Yeah, so the ranking, here, like I said before, the MSRA results came out February 8th. Um, you're uploading your evidence between the 8th and the 14th. So you find out whether or not you're eligible to continue in the application process based on your score. If you're in the top 1200, you'll move on to the uploading evidence and eventually the interview. And then the interview window happens in uh, February 19th to the 28th. And from February 13th, you can start preferencing your jobs of what you would like to do. So last year there was, I don't know, 612 jobs or something. So that's when you do the preferencing, sort of after your interview.
Okay. And do you have any recommendations as to how people should rank? Should you rank all of them? Should you rank only the ones that you're interested in? How does that look?
It entirely depends on each person. If you really want a job in core surgical training, to later, apply for whatever your desired specialty is, it makes sense to rank every single job. It depends, on many factors, what jobs you want to do, where the jobs are. For example, when I was ranking, I wanted to stay local to Cardiff. My wife, she works in Cardiff. She's here full time. So I didn't want to move away. That wasn't really an option for me. So when I ranked jobs the first time, I ended up getting a job, a couple hours away. And I'm like, that's not going to happen because, I'm not going to, one, I'm not going to move there. And two, I wouldn't drive 2 hours every day to work because that's just suicide. So then there's an option where you could upgrade your job in terms of if you want to give back your job to a pool and then re-rank jobs, you could do that. And then I ended up matching in Swansea, which is sort of next door to Cardiff. And it was trauma orthopedic theme. So I was over the moon with that. But there is a bit of strategy involved in terms of ranking, depending how good you do in your full application. If you rank first in the country, which is very hard to do, but someone does it every year, they pick whatever job they want. If you're not confident in terms of your scoring for your self-assessment and your MSRA and things like that, and you know that you're not going to be top of the pack, I recommend ranking a lot more jobs because you'll probably get a job. There's always a possibility to upgrade your job if something becomes available, which I got lucky in my case. But it depends if you're willing to move and if you're willing to take any random job. So they've changed it now. So all of the CST jobs are 6-month intervals. So usually they'll give you your first job for 6 months. And then if you're doing a themed sort of rotation, meaning you eventually probably want to specialize in that specialty, they'll give you 12 months of that job in the middle. And the reason they give it to you in the middle 12 months is because that's when the applications for registrar training will come out. So you'll be in that job, you know what you need to do, you become familiar with the job, and you'll be able to maximize points, hopefully, for your specialty applications.
If you are matched into something that just you're not interested at all, is there a problem with just declining it?
No, most people can decline it. If you match to, I don't know, let's say, I think my first job was urology themed, and I have no interest in urology, so I gave it back. And I think there's different options. There's hold with upgrade. There's flat out reject or something. I can't remember exactly the options. But mine was to give back with an upgrade. So if I didn't get anything better, then I think you may not get anything better and then you lose out on a job. So it depends how much you want a job and things like that. But if you want to give it back, it's entirely up to you, because if it's hours away and you don't want to move away, so, there's no point.
When do you find out your score before you start ranking? Do you actually know
I think
your
at the
score?
same time. So at the same time you're offered a job, you'll see what you match to, and then you can see your score then, your entire score and your ranking.
So before that, you're kind of guessing what your score is.
Yeah, you have no idea. So not until I'm pretty sure from what I remember is when you match, that's when they show you your score.
And then you said ranking. Did it tell you what rank you got in the country, or?
Yeah, so you'll also see that you scored, 300 out of 1200 or whatever it is. You might know your score before the jobs come out. I can't remember exactly now, but there may be a
I'm
possibility
curious
that
how you can use it to, let's be a bit more calculated with what you apply for.
no.
So how you
No,
rank for
no.
job.
I'm pretty sure the ranking scores you won't know until after you submit your all your rankings.
Okay.
So after the rankings are closed, then you might see that you rank 400th or whatever. And then if you've applied for 600 jobs, you know you're definitely going to have a job, because even if it's the 400th one, that'll be your job. But some people want different jobs, different locations, so you can never really tell what job you'll get, really, because everyone's different with what they want.
All right. Okay. And then after that, beginning of August, you
Yeah,
should
you
probably
start your
start.
job. You'll be 6 months in your first job. There's different things you need to do. So there's a portfolio called ISCP, which you need to keep up to date. Essentially, you need to do work-based assessments, get your consultants to sign off things that you've done, procedures, observation of different surgeries. You'll have your e-log book where you upload all the operations that you've been a part of or have done yourself. Many different things, but the ISCP is the main thing, because every year you have an ARCP, which is an annual review of competency performance or something, I can't remember, where they evaluate you as a doctor and look at if you've met all the criteria of what you had to do. So you'll get different outcomes depending if you're on track to finish everything. In core surgical training, if you want to, the whole point of doing core surgical is to then get a specialty registrar job in a chosen specialty. So you'll need to complete MRCS Part A and B. So I'm finished with A, and I still need to do Part B, which I'll get done this year. And then I would apply for registrar training at the end of this year for next year.
All right. Okay.
But
And
that could be a different session.
I think so. You said, I think it was ISP and ELOG.
ISCP, yeah.
ISCP. Are those things that you can already contribute to prior to?
No. So ISCP is totally based on everything you do in core surgical training. So if you have any conferences that you do during that time, you'll put it in there. So yeah, it's nothing to worry about before you get into core surgical training.
And what about the ELOG?
E-log book is the same thing. E-log book you could do in F1, F2, because that's where you will upload your operations.
Yeah.
So you'll have your GMC number, you'll make an account, and then you could start logging in operations from F1.
All right. Okay.
And then that's where they'll take the 40 operations from, where you could print a script of all your operations. You'll need to get it validated by a consultant where they just put their signature and GMC number at the bottom of the sheet. And then you submit that as your evidence when you apply for CST.
Okay. I think we've pretty much covered everything. So I'll just ask finally,
Nice.
Do you have any other additional comments or anything else you want to share about the process?
It's long. It is, yeah, like I said, it's getting more competitive. I didn't have to do the MSRA, thank God for that. But each year, and I'll send you links to the website, in terms of the competition ratios, they're increasing. My recommendation is obviously try and stay on top of everything. Maximize points as best as you can early on, because as you progress in your training, things become more difficult. I have a child on the way next month, so things aren't going to get easier for me in terms of exams and as things carry on. So yeah, you got to be on the ball with this type of stuff. And if you're committed to surgery or whatever specialty you want to do, there's leaps and hurdles everyone has to do. Exams are a tough one, which take a lot of time, to study for. When you're working as a doctor, studying for an exam is, one of the last things you want to do, because the amount of time you have and you're just stressed from your job and things. So yeah, you just you have to stay organized, have a balance to everything. And I just recommend getting stuff done earlier rather than later.
Okay, perfect. So thank you very much. Really appreciate you for doing this.
No problem.
I think it'll help a lot. So
I hope you guys have learned something. But yeah, if anyone has any questions, or anything, I can provide my email. People can get in touch with me. And then, like I said, I will be hosting, hopefully in the upcoming months, I'll be hosting sort of like a review of getting into foundation program and application processes and things like that. I run like a little course which will be online and people could log into, so we could advertise for that at a later time. But yeah.
Perfect. We'll definitely promote it. For sure.
Awesome. Thank you.
All right.
Thank
All
you,
the
guys.
best. Thank you very much. Please tell us what you liked or disliked about the video and ask any questions in the comments. If this video is useful, please give it a like. All links discussed in the video can be found in the description, and please use those links and subscribe to the channel to support us so we can keep producing content. Thank you, and maybe watch another video.